Good afternoon, everyone, and welcome to Philanthropod Live. It's so great to be here with you all in Melbourne and with these two individuals, Surya Bhatta and Dr. Ben Wachira. Surya Bhatta is the co-CEO of One Heart Worldwide, and they work towards supporting mums and babies surviving childbirth. Dr. Ben Wachira has the unique distinction of being the first emergency physician in Kenya ever and the founder of Emergency Medicine Kenya Foundation, and their work has transformed the way emergency healthcare is delivered in the country. Both Surya and Ben work on the front lines of health. They're working with systems that haven't been in place or are rudimentary at best, and they're here today to share their story with us. Welcome, Ben. Welcome, Surya. It is so wonderful to have you both here.
Thank you.
Thank you.
Now, I thought we could probably start at the beginning and start with the context of your work. Surya, you're from Nepal, the home of Mount Everest, wide-ranging mountain ranges, which makes healthcare quite challenging. Your mum's birth story inspired you a lot. Can you share that with us and how maternal healthcare has become quite personal for you?
Well, thank you for everybody for today. I think it was a great honor to share my journey here and work with you, all of you. I was raised in a small village, just learning English very, very late when I started working in, this sector. But one of the really important thing, what really I carry with me every day is like the story that, a lot of mother has really gone through, and this is one of them is my mom. She was married when she was 11, and my dad was 13. And she has first child when she was 16, and it was a really complicated birth. She didn't tell me this until I was doing my public health degree. And so, I was learning about public health, maternal health, newborn health. I just asked her, how was your birth experience? Because Nepal still has a very high maternal death. That was really context how I got to learn about this story. And then she told me, I had really kind of a, challenging birth. I was, pregnant young, and then I had baby, sister, she was the first one. And then she said, my placenta did not come out. And then they hang the garden hoe on her placenta, because that is really traditional practice they would do when placenta doesn't come. And she told me I thought I was not going to survive, but very fortunate she made it. And then that really, she didn't really say with very lot of kind of, she didn't really feel like it was really challenging. She accepted it as like a regular life challenge for being a woman in the village. But that was really kind of a moment like, okay, she was just a near miss. She really survived. And that was really a moment like, for me, okay, I'm working in this space, I will do something that is meaningful. So, the birth experience is very different for other women I work with. So that was really my, journey as a home village boy. Learned very late, this language and, culture and people. But right now we are we're one of the leading maternal newborn health NGO in Nepal, working in 5 provinces, serving almost 1/3 of the geography, but I will come back to that details later. That is really my journey starting in this sector. Thank you.
Thanks. Ben, that would have been an emergency situation for you. Now you're from Kenya, very different landscape, land of safaris and savannas, but equally challenging to access healthcare. You grew up wanting to be the hero on the show of ER. Tell us your story and what you've learned about being an emergency physician over time.
Thank you, Anubha, and thank you everyone for coming. And yes, good afternoon. I think, yes, I wanted to be George Clooney, just to be specific. So I grew up watching ER and thought, yes, it would be nice to save lives. Sounds like something cool, and looked cool, actually. He made it look cool. Well, so yeah, ER without all the romance part of it. And so went into medical school in Kenya, and it was a fantastic experience. But I think the key thing that I really noticed was anytime an emergency showed up, we all panicked, including the consultant who was supposed to be showing us what to do. And we weren't actually taught what to do when someone comes in not breathing or they're unconscious, because most of the patients that we saw were patients who were fairly stable, needed some injection or some tablets. And so finished medical school, still not knowing how to handle emergencies. And I was like, wait, but I wanted to do what I saw on TV. I wanted to be the hero. Well, not in a, but I wanted to save lives. That's what I went to medical school for, not really supervise people dying, because actually that's what we did, because every time an emergency happened, we all panicked and did something, but of course, sadly, the patient died. And I was like, I didn't go into medical school not to save lives, and not so. So I finished medical school and started internship, and this was now my first time where the patient, I was the main doctor. There was no one else around me, just me, and it was a mess because I just didn't know what to do. And luckily, it was the same time Google was showing up. And so Googled around and figured out, oh, there's something called emergency medicine. So what they were doing on ER and on TV was emergency medicine. But that didn't really exist in Kenya. So there is no 000 number. There are no public emergency departments. There's no public ambulance service. So that was just non-existent. So the panic that we were feeling was because it just didn't exist. Google around, figure out, okay, so South Africa, Australia, the US have all this emergency medicine. But of course, I couldn't afford that. And so decided to do some short courses just to learn a bit more about emergency care. Got an opportunity to go to South Africa to do some of these short courses. And then in that same process, got an opportunity to go do my master's in emergency medicine in Cape Town, and got a scholarship from the Aga Khan University. And so went to South Africa for 4 years. It was way cooler than ER. Yes, emergency medicine is amazing. And yeah, it was like ER on steroids and like so cool. Got a lot of time, opportunities to save a lot of lives. But I think the key thing that really stood out for me was all these patients I was busy saving in South Africa, I had never seen even one of them in Kenya. And I realized it's because they just never make it to hospital. I mean, if someone's been stabbed in the heart, in South Africa, you'll come in, we'll patch you up, and we'll have a nice conversation tomorrow. But in Kenya, if someone stabs you in the heart, that's it, you're done. Like, there's no way for you to actually access any emergency services. So came back in 2012, then as I said, was the first emergency physician in the country. And for me coming back, I think my key purpose was how do we educate healthcare providers? Because I was a healthcare provider before I left, where I was completely clueless about what to do. So how do we educate healthcare providers to provide that emergency care? And yeah, long story short, that's how the foundation kicked off.
Fantastic. So you've both seen the human cost of lives in systems that don't quite work. Surya, you've been trying to prevent maternal emergencies. Ben, you're trying to support an emergency system. They're both very overwhelming tasks. There's a lot of different variables, a lot going on. Can you explain to us what problem you are actually trying to solve at that time? You've mentioned a little bit about the start of it, Ben. But Surya, like, what's the context like in Nepal? What are you trying to solve?
Well, let me break down this in just 3 simple pieces. The first thing, we're trying to improve the access of care. A lot of region where we work is very mountainous, rural, and just inaccessible to get the basic antenatal visit, delivery service, just the basic maternal newborn health service. So that is really something we are trying to solve through the different program, setting up a birthing center, training nurses to become a certified skilled birth attendants, providing the required equipment for those clinics, and training the communities how to run this. So that is something we're trying to do. And the second thing is quality of service. In this region, the service quality really needs a lot of work. So, do you have just basic medication? A lot of things what we do is very similar. So maybe, there's a lot of overlap in terms of the needs. That is another big challenge. How do we solve the quality issue? Because if mother is not getting service different than what she's giving home birth, so that is really the challenge that we have to deal with, preparing health facility nurses to provide the dignified quality health services. And third one is how do we sustain this work with the community and government, because we are not there always, savior. We don't call savior, even though we save life every day. So how do we sustain our model? How do we really ensure that the government is upfront, taking full ownership. At the end of the day, we have a 6 years model. I will talk later. So that is another, areas that we are trying to solve. How do we have a government ownership and buy-in so the program really continues once we exit from the district? So these are the really key things. On top of a lot of cultural issues, not trying to come to the facility, the education that the families, and then the traditional practice of not being, using the modern facility, modern medicine from the generation to generation. So these are all other underlying causes that we have in our sector. But just to narrow down, these are the really key 3 things we are trying to solve. Thank you.
So you're trying to make sure that women don't use a garden hoe to remove a retained placenta and get access to healthcare. Ben, what's it like for you? Obviously, there wasn't an emergency system set up. There was casualty and accidents. What were you coming into from South Africa where you went, right, this is something I'm going to have to work towards step by step?
So I think it all boils down to, the hospitals existed, but there was no actually emergency department. It just a room where all patients kind of got in, and if you survive that area, you go into the hospital wards and all that. And the vehicles existed, so vehicles with lights and sirens. I don't want to call them ambulances because they don't have anything inside. It's just a vehicle with lights and sirens. So they existed to move patients from hospital to hospital. But if you were hit by a bus, there was no one coming for you. No lights and sirens running away. Even the police are not really coming. And if you're, like Surya's perspective, you're a mother bleeding in the community, there is just no one. So most of the time, and people don't have private vehicles. So most of the time is you have to figure out, does your neighbor have a vehicle? If most of the time, no. Can I get a motorcycle or public transport? So many people die before they actually get to the hospital. So coming back, I think the key thing was, and that's the other thing is, I think one thing that was very clear to me is there's nothing like private emergency healthcare services. Emergency healthcare, the people who need emergency healthcare service cannot afford the service. It's not the time where people are like, all right, how much can you swipe your card as you're busy dying and see if that really is gonna, So it has to be government-driven emergency services. And so for me was, how do we build an emergency healthcare system within the existing infrastructure? How do we upskill the existing healthcare providers? Because we're not going to say, let's send everyone to school to become emergency physicians. It's going to take some time. And patients are dying every single minute. It's 57 people die in Kenya every hour. Whether we fix the system or not, they will still die. So it was how do we work with the existing infrastructure, existing system, build up on the existing policies to start providing emergency healthcare services to the perspective where someone out in the community who has an emergency can have a number to call. A vehicle will come pick them up. To be honest, I'm not even talking about any fancy ambulance services. If a vehicle can come pick you up from the hospital and then take you to a designated space, or let's now call it emergency department, where the healthcare providers know exactly what to do. They're not clueless and they're not panicking as we are panicking. And are able to provide that stabilizing care for you. I think we'll have achieved quite a lot. I sat through your 000 number, listening to the calls, I think last week, and in Sydney, and it was quite interesting. That's people call in an emergency. People just want a number to call, and like the systems here and other Western countries, you call that number and then you just relax because the system will take care of you. We're just trying to fix something like that where the system actually takes care of you.
So Ben, obviously there are private hospitals in Kenya where there is an emergency service and there are ambulances. You've chosen to work in the government public health system across the 47 different counties, it's a devolved system of government in Kenya. You've chosen to work in quite a hard and complex setting. Can you lay it out for us in terms of how you exactly started and sort of what the steps are at this point, right from the protocols that you published to now the ambulance services that you have put in place in the 10 different counties? Can you sort of describe that work in terms of how far you've gone?
Okay. Just for context, yes, as we have the federal government and 47 state governments, we call them counties back home. So I work with 48 governments. It's a bit painful, but yes. It's 48 different politicians, and yeah, it's not fun. But I think when we came out, so 2012 to 2015 or so, we wrote up protocols just so that we could ease, and that's the time social media was actually kicking off. So we published a lot of our emergency care protocols on social media to allow people just access information. That's first we also set up the website and just provided all this information. And from that work, because that really caught on like wildfire, because remember, there are healthcare workers who are seeing patients, but they have no idea what to do. So the moment we started providing them with some information on what to do and some guidelines, they were really excited about it and kept asking for more and more, and really pushed us to develop more and more protocols. And from that also, we also started being contacted by the government to support in some training programs, some policy work. And actually so before 2017, the only thing that existed in the constitution was a line, every Kenyan has a right to emergency healthcare treatment. That was it, nothing else, no policies, nothing. So come 2017, we actually had a whole change in the constitution. And the Health Act 2017 pretty much crystallized emergency healthcare as a key component. In fact, it was tagged next to maternal child healthcare. So every mother has a right to maternal healthcare, and everyone has a right to emergency healthcare. So we worked with the government to come up with that law where that was put in the law and become a right, and there are penalties if the right is not provided. It's the first time that actually the government talked about having an emergency care fund. But government policies are nice and laws, they're nice on paper. Getting to the ground becomes a bit hard. But at least for us, it was a start. And the good thing about that is then that put it in the law, and that became the guiding principle for even some of our work. So in the same year, emergency medicine was recognized as a specialty in the country by the Medical Council. And then progressively started working to map out the emergency care centers. So at least 265 hospitals had the basic capacity to start providing emergency care. And of course, then we have the 47 public ambulance services that need to be built. Come COVID 2020, I know many people died, but COVID was actually a blessing for emergency healthcare services, because all of a sudden government realized, oh, we need ambulances, oh, we need oxygen, oh, we need emergency departments, and oh, they don't exist. So funny enough, so we had done a lot of research in the couple of years before that. And so we were actually giving government data that they didn't have. Where are the emergency care centers? Where should patients be taken to? Who has oxygen? Who doesn't have oxygen? Where are the ambulance services? And actually post-COVID, because of how bad that whole experience was, come 2021, the government actually launched the first ever policy on emergency medical care in Kenya. So the Kenya Emergency Medical Care Policy 2020 to 2030, that pretty much laid out the blueprint of our emergency healthcare services. And that was launched in 2021. And as of 2023, we actually set up now a proper emergency care fund. It's currently being operationalized. So we've seen the system grow from zero to now we have very clear structures, very clear laws and policies on emergency care, and have well-defined structures around emergency healthcare services.
Fantastic. I mean, that's quite a journey to go from zero to not 100, but close. Surya, in Nepal, your theory of change is called the network of safety, where you're also working alongside local governments and public health facilities and primary healthcare facilities to upgrade and upskill them. Tell us a little bit more about how that model works and the various components of it.
Well, Ben has really explained the nuances with government. Partnership is always a challenge. It's a home. It's everywhere. But that's also the best way you can leverage each other's strength. So we see that is a opportunity for us. One thing what we have been really successful from the beginning is we have put their priorities as a front, because every country wants to improve the maternal and newborn health outcome. They have committed, improving. Our goal is to reduce the maternal death by 70 by 2030, hit our sustainable development goal. Reduce the newborn death up to 12, but how? So that is really kind of, we put our I think the discussion in the table. This is really what we want to do it, and there's a partnership. The spirit of the partnership comes with the common goals and objective, and then that's where we bring our expertise and our knowledge to support the government. We work in a various different level. In the federal level, a lot of policy system change. We work with the provincial government. We have a 3-layer of government in Nepal. Local government is basically responsible to provide the basic primary healthcare service, where we have a lot of our program is. And then the provincial government also provides a lot of those kind of support to the local government, which is the municipality government. And then federal government is, a lot of policy system, guideline. So we work across all of these 3 government system, though our program is mostly goes to the rural municipalities, where the actual program is done, like we do the training, set up the birthing centers so women can come and deliver babies and do the antenatal visit, work with the local municipality, how to really prioritize the local budget program and everything. So one of the things that I wanted to highlight here working with government is, we have a 6-year model we call network of safety, network of care. So once we go to the region, we sign the first discussion with the Ministry of Health, federal government, and we talk about this big goal, like Nepal has agreed to reduce the maternal death by 70. We're at 151 now. So what we do, there is a lot of clear policies in place, as he said, but how to get there is not very clear. So that's really where we bring our expertise, and then after that is being done. We set up the plan, we go to municipality. So what we do is we go to every district. In every district there is like 10 to 20 municipalities. So every district we go there, do the need assessment, do the baseline, talk to the community, visit the facility. So that really gives us the idea what is happening out there, what are the needs. So it is not like a very customized, ready-made program. Then when we start this conversation, then they really kind of feel like, okay, we are a very important part of this conversation, and we make it very clear from the day one. It is not the donor model, it is a partnership model. So you have to pay 50% of the cost of the program in many places, especially when it is infrastructures, birthing centers. That is what we do a lot. They have to pay 50% of the infrastructure cost. And then training, they have to do they have done in around 30%. So we talk about the needs together, discuss about the plan, and then after this discussion, we go with the agreement. It's a written agreement that we do with, because sometimes it's, as he said, politicians, it's hard to get their commitment. So we have to do written agreement, especially when there is a financial kind of commitment being made. So once that is done, and then we work with them for 3 years, which we call the active implementation period. So 3 years we do the investment together with the local government or provincial government. And then after 3 years of full implementation, we move to the transition, where we don't do the active implementation. We just do the more mentoring, support, technical help, but nothing to do with the finance. So they have to take over everything. That 2 years is kind of a period where we watch out things, whether things are being done or not. We call like a sustainability path. And then once they are really taken care of everything, and then after 6 years, we leave the region. There has been incident that sometimes we do more, the implementation period is sometimes 4 years if they have a lot of need. One of the things what government, I should really highlight about this is, when there is big needs happen, we are always there, even though we are not an emergency organization. When there is COVID, we ran a big support. One of our, a partner was supposed to come here from direct relief, but he got sick today. And then, Anubha and Marnie is here, we ran this oxygen, flew through the plane from China to Nepal, and then the earthquake, and then always something happening. We have been always there sitting and standing with them, as Ben mentioned, supporting government. They really value this. They really value the presence that you show, solidarity you show when there is an emergency going on. So we're always there, together with the government, sitting with them, learning from them. We share our data, they share their information, and then we're really together in a same journey. That really has helped us to shape our program really well.
You both talk so much about co-creation with governments and collaboration with community health workers, and it all sounds fabulous. You've mapped it right out for us. 6 years, we're done and we're gone. It cannot be that easy. Tell us what the challenges are.
Well, let me start, Ben. One of the things I'm very proud of my team is, I'm representing everybody. one of colleague, who used to work with me long time as a partner with Medic. He's right here and watching me, which is really fascinating how difficult working with government and partnering. This is really, partnership is always a challenge. I think for them also, it's not for only, because we come with our own interest and they have their own priorities. And then how do we really come in a, right place so we also meet their, needs and also our expectations. So there are a moment that, we had a moment that, okay, this is not going to work, but you just need to be very persistent. You have to be very nimble and flexible with your effort. And they also, understand who is making genuine effort. Are we really, coming with our own interests, or really trying to be responsive to the need of the community and country? That is really what they care about. If you are coming with your own interest, it's flying in and out. It's like projected model versus model-based program. We are here to make the tangible changes in maternity health. That is really our goal. That really changes the whole conversation, and it is by you and to you, and we are here just as a technical support. So there has been I wanted to share one interesting story. There was one time one of the municipality mayor called me because this infrastructure has to be done by 50%, and then he was calling me, I'm not going to give 50%. And then, okay, and then what you want to do? I want to do 30% because you are a funder, you must have a lot of money, so you do 70%. And then, but that's not a deal we do. If do you really want to build a birthing center or not? No, we need to build a birthing center, but I'm not going to give it. And I just try to convince, how many people, mother in your community and everything, he was like going on, and then, okay, this is, if I do this with you, I have to do with others. This is really what we have agreed in every municipality we have worked. This is really what we expect. The partnership comes, it's not only in paper. That is a genuine partnership comes when you commit something. We are committing because it's your community, your mother or your sister, your families, and that's really what you are doing there. And then he said, I want to try if you wanted to give more or not, but I'm okay going 50%. That's really kind of end of the story. So this kind of conversation has happened a lot of time. And there has been no instant that government has really dropped from their commitment. We have done over 100 plus birthing centers, construction or renovation and support, and 800 plus like equipment support. We have never had a chance that government has withdrew their commitment. It is a slow. We have to meet with their physical like a budgetary cycle. That is a long process. Every government has their own like a due diligence and process. It takes time sometimes to do things. That's why we needed this 6 years of model. We could have done it maybe 4 years, 3 years. But when you go with partnership, you have to go within their pace. You just cannot go in your own speed. But when you go together, you go very strong, and then you win. So that is really kind of a challenges we are facing, and that is how we are also navigating.
Mm-hmm. That's very interesting to go at the pace of the government. Ben, how about you? Like, what are your biggest challenges working with the government?
I think Surya has mentioned a lot of them, but I think there's something that is universal around emergency care. Whether you're sitting in Australia or you're sitting in Kenya, whether you're a politician or just a common person, unless you're lucky to die in your sleep, at some point you will need emergency care. I think that is something that has been a big reality even to our politicians, because they always think, oh, I have money, I'll fly to India, get some fancy care. But I'm like, well, you may not make it to that plane. And we've had lots of instances where politicians have sought emergency care and not found emergency care and died by the roadside. Very famous politicians have died by the roadside, trapped in a vehicle and no ambulance was coming, or had a heart attack and just didn't make it to hospital on time, and because there's just no one coming. So I think that's a key realization. That's where we start the conversation from, in terms of, because sometimes politicians think they're building healthcare systems for those people out there, those people who can't afford things. But emergency healthcare is about everyone. And so so the first part of it was just to help them understand what is emergency healthcare. But I think the second part of it was also to break it down for them into small pieces. Because if you're going to tell a politician, we're going to build a whole 000 system with fancy emergency ambulances, they're like, on whose budget? Yes, that budget doesn't exist. But breaking it down into small, tangible pieces, and then also building it block by block, okay? So from the small, training community health workers, improving one emergency department, setting up just a dispatch center. So it's building it block by block. And the interesting part is we came up with the blueprint for the country's emergency healthcare services in 2018, 2019. We are the only organization who knows how the whole thing works. Even government doesn't actually know how it works. They've been working with us to build the different pieces and are now starting to see the connections. But we built the blueprint using the WHO emergency care system framework. And so this time we're like, oh yeah, let's support emergency department there. Let's help you write a policy on this. Let's help you. So we know where we're going. And we've been at it, I guess, I said before, from 2018, 2019. So it's helping them see slowly and that's the other thing is, if you give the whole picture to government, they get confused. Yes, they're like, this is just too much for us. So by giving them pieces by pieces, we've been able to form those relationships and trust. I think that's the other thing about government is you have to spend more time listening to them versus talking to them. Because there are some things we have learned. In fact, we've learned so much from the government in terms of how the healthcare system works. Because, and I mean, if you ask every person, and I'm sure you'll ask Australians here, does your government work? No, those people don't work. Yes, they just take taxes. But over time, you start understanding how government works. And a deeper understanding of how government works is what helps you then come up with solutions that will work in their system. So you can't come up with a parallel system. Government is government, and government will exist even when you're dead. Yes, and so having an in-depth understanding of the government, and we spend tons of meetings with government, just understanding how things are working, and then from that coming back to the drawing board and coming up with our own. So we do a lot of research then to figure out how is this emergency fund going to work in Kenya, where we don't have all the money. We need to save lives. And so how do we build it something that the government will easily adopt? So lots and lots of research to figure it out. And then, yep, just conversations and conversations, yes.
I love what you say about working in tandem with the government to find the solutions. So tell us the impact that Emergency Medicine Kenya Foundation has had so far. What are some of the numbers in terms of, upskilling community health workers, your protocols, the emergency health departments that you've been able to upgrade, and the ambulance service? Tell us, what does that look like today?
Right. So we started with zero, okay? It was a nice clean slate to start off with. But the facilities existed, the healthcare workers existed, vehicles that have lights and sirens existed, okay? And so we came up with the emergency healthcare protocols that are used across the country now. We did a mapping to figure out, because we have over 6,000 healthcare facilities, it's impossible to have 6,000 emergency departments. So we did a GIS mapping to figure out the population distribution versus the distribution of the healthcare facilities, and which are the facilities most optimal that already have some basic infrastructure. And there are 265 facilities that we now support to become emergency care centers. And everyone within the country can access this facility within at least 96% within 2 hours, and 90% within an hour, which are the WHO standards. And so we've reached 165 of these 265 facilities. We started with no public ambulance service, and as I said, we have 47 states. So that means we need to have 47 public ambulance services. So right now we have 10 states that have public ambulance services. You can call a number and a vehicle shows up, and we built the technology behind that. We have an app that's used across the country. I think there's over 10,000 downloads so far. That helps even the general public learn emergency care and who to call in an emergency. We've trained over 6,000 healthcare providers who now are the front line of this. And yes, just to mention the policies, yes, so we've changed all the laws. I think that was really the success. All our laws are very well aligned in terms of provision of emergency care. And even with the state governments, we supported 30 of them coming up. 30 of the 47 states come up with clear policies around emergency care. I think 20 of them are already implementing this. So the policies also help government budget and fund emergency healthcare services. So down the line, even in the absence of us as an organization, the government has already put the laws, put the policies, they've put the budgets to it, and yeah, it's going to take 3 to 5 years to some of the budgets. So our target is at least have 50% of the system built up by 2027. So that's 24 states having functional. When I say functional again, you will call, a vehicle will come and it'll take you to a center where you can get some emergency care. Of course, there's a lot of work that needs to go into it, but at least if we can achieve 50% by 2027 and 100% by 2030, I think we'll have done a good chunk of our work.
That's brilliant. I love that you're very pragmatic about it. It's not building the whole system at once, it's building it chunk by chunk. Surya, maternal mortality in Nepal has trended downwards. A lot of that has to do with the impact of organizations like yours, but also the commitment of the government. What's the impact that One Heart has had?
Well, let me talk about some numbers first. So one of the core, our program model is improving the capacity. So we have trained over, 800 nurses to become a certified skilled birth attendants. We have supported around 800 plus birthing centers. So they have equipment, supplies, just all the resources they needed to function, to provide a quality health service. We have trained over 22,000 female community health volunteers and healthcare providers over the last 15 years. In a region where we have worked, and one of the things, we feel very proud is that is just a number that we have achieved, but also in terms of success, the region where we have worked in municipalities, over almost like 97% of municipality has put the designated fund for the maternal newborn health service on top of designated fund given from the federal government. So they have been prioritizing their own money, one budget, just to serve the mom and baby. So that is really one of the big success we celebrate. In terms of maternal health, yes, we have made a huge progress over 20 years. When I started, that was a time when I was having this conversation with my mom. Nepal has, one of the worst maternal death, 539 per 100,000 live birth, versus we are now in 151. But our goal is just, to go to the 70. We need to really halve the maternal death just the next 5 years, which is maybe less than 5 years now, around 5 years time. The same with newborn death. We were really extremely high, and now we are kind of in a place, we are kind of stagnant from last 5 years. So I think in terms of our success, it's not only look with the number, but also a lot of, what Ben said is sharing the best practices, bringing some system level change, policy changes, drive. One of the things really I think worth to really mention here, which is also funded, supported by DAC. So this, small ultrasound program that we were doing in a small remote district, one of the remote district, Olpa, where I work a lot in the beginning. Very, very remote, no road access, just everything by foot, and largest district in the region. So you have to really walk several days to get to the district hospital. And we started in those regions, okay, if the pregnant mother has the access to the ultrasound, so she knows the complication in advance, she can come to the district hospital, can have a CS or anything she needed. So we started as a small program. Then, it was really taken care, it was taken so fast by government. We really basically provided some ultrasound machine. And then, we realized government is very interested to really take this as a great, program. And then, so we started really working on protocol guidelines, so the service is really being provided quality service. So we set up, we work with the Ministry of Health, National Health Training Center, finalized their training curriculum package, and it just became a government program now. So now every municipality that we work has their own ultrasound machine that is accessible to every pregnant mother through their, outreach clinic program, because it was only available for the nurses, for the doctor, in the district hospital. So most women would not have these services. And then what we learn is, okay, if it is really working in Nepal that well, government has taken this so, like smartly. So let's do this in other countries. So we started this model expanding in 5 other African countries: Togo, Malawi, Rwanda, Uganda, Kenya. So we are taking up that through the support from the DAC. And this is really kind of the work that we would like to bring the best practices and then scale, wherever it is relevant. One of another training model which we have been just able to scale to the national level. A lot of this training, clinical training, is done in a hospital-based setting, that they go to for several months, and they are away from their hospital or health facility, and then there is no service provider. We are always sort of the like healthcare providers in remote clinic. So sometimes even the services being closed, because the nurses are gone for the training, and then they come back, and then they don't have any support system. So they tend to lose their clinical skill and knowledge and energy. So what we did is now we changed the way. So the nurses from the bigger hospital go there with the mannequins, training materials. So she sits there, oversight everything. And then we call low dose high frequency. When you teach something every day is better than when you teach one person for 1 month in a closed room. So we changed the way how we want to do this mentorship model. Now it is becoming kind of government program. Government has taken this as a national program. Before I come here, there was a protocol finalization meeting with the Ministry of Health. So we are really making a lot of different changes in a policy system level, plus working in the community where the need is really high.
Fantastic. So you're both really working to build systems and protocols that can be then scaled countrywide and nationwide. And I think because your work is open source, that has then quickly taken over, and the government has adopted that very, very quickly. So what's coming to my mind is you've set it all up, the system is great, everything's working fine, you're achieving your goals, and then disaster strikes. You have an earthquake, COVID or a pandemic, or in both countries, Gen Z protests recently. How do you both work to ensure the system continues to work despite the challenges of a disaster?
Well, let me start with this one. I think we have a most disaster than anybody. So let me take you back to the maybe 2015 earthquake. I think that was a moment we realized, we need to have a backup plan. Even though we are not emergency responding organization, we are very mixed of public health, medicine, or nurses, just doing a lot of public health intervention, improving health, in the rural areas. But this kind of disaster has really given us a moment. Okay, we are, nothing is permanent. First, neither our life or not any healthcare infrastructures. So a lot of these, facilities has been destroyed. So woman does not have a place to go and do birth, and they don't have a place to live. So it has been a lot of challenge. And COVID seemed like there was a challenge. So every time when there was something happen, we have really been able to navigate in a very, very smart way, I would say. And I want to give credit to my team and the government really participating in this interesting kind of situations. So we were able to set up like a tent, permanent, some temporary tent. So set up a kind of a just like proper health facility. Like a day, we have a wherever the health facility being destroyed, but we go next day, set up like a tent. There is delivery bed, nurses are there. So we provided those transition support, and then long term we have like a recovery rehabilitation plan. So we work with the various government partner and funders. Then we were able to resume the service right after the situation like that. And COVID is one of the moment I think we really felt like end of the world, but also that gave us a lot of new ideas, new thoughts, as Ben said. Yes, it was blessing in many ways because we were able to innovate a lot of things. One of the things I wanted to highlight is there was transportation was closed, so people are not coming. What we saw is a lot of women stopped coming to the big hospital, so they are stopping to come to deliver. We were looking the numbers, so where they are going. So we learned that they're all living village, going to living city and going back to their hometown, because anyway we're all migrant here and there. So they were also living their city and going back to their village town, and they are giving birth in the remote areas like birthing centers. And then when there is a complication, and then they call our staff who are based there. If they have complication of prolonged labor or something, obstetric labor, then we are starting to get a lot of calls. And what to do? So then we talked to the Ministry of Health, Family Welfare Division. So we are seeing this, and then they also looked the number together. They saw the significant shift in their service delivery, because these big hospitals are not providing same level of number of deliveries, and so that was now moved to the remote areas, and that really created a lot of challenge. So what we did is we sat with the government and then the Society of Obstetrician and Gynecologists, which is like a group of doctors, obstetrician, and then we decided to run the helpline. So anything goes, so the nurses can talk to the family, so she calls in free of cost. So we provided the top up in a phone top up, like just like in a month, like $2 something. So they could call every pregnant mother in the region and find out who is there. And then when she has a complication, and then she can talk to the doctor or obstetrician when there is a complication, because these birthing centers are not equipped to provide CS service or complications. So they needed someone to help like real time. And so we were able to really do a lot of things this time, even though one phone can really save lives. There are a lot of stories that we have. We are publishing that in peer-reviewed journal, which is about to get published in next few weeks. What we learn about is emergencies are inevitable. This will be there always, but we really need to be creative and innovative. We can deal with this, and we have been dealing with all of this problem in a very different way.
Fantastic. Ben, you thrive in emergencies. COVID was an emergency, which the emergency departments were then on call, which
yes.
there weren't that many of them. What was it like for you?
So I think, of course, Nepal has way more natural disasters than we have. I think what we have abundance of is man-made disasters. So lots of terrorist attacks initially. Thank God they've gone down, but we've had a couple of shootings around. Our road traffic crashes are insane. Right now, recently, actually had flooding. In all instances, the gaps in emergency healthcare really come out. I remember, for example, COVID, sitting in one of the administrative people's office in the Ministry of Health, and they were essentially a dispatch center. So, and I remember having a conversation with her and asking her, how is it you are the top of the healthcare system and you are busy coordinating ambulances and looking for beds, because of course then there was a shortage of beds. And I think, well, that same administrator is the one who signed the policy after that immediately. They were like, no, we can't continue existing like this. So I think emergencies have highlighted the gaps in the system, and the more emergencies we've had is the more the government has responded, because we're not service providers, we just support government. So when, for example, COVID came out, we came up with the national protocols for emergency care for COVID, and had those ones being used across the country. When hospitals didn't have emergency departments that had oxygen, we then responded with support of partners to put up oxygen piping systems in the emergency departments we'd already mapped out. So I think a lot of the work that we've done and what disasters and emergencies have highlighted is the gaps in the system, but also an appreciation that we have to have an emergency healthcare service. And with every incident that has happened, I mean, we just had flooding recently, and they're like, oh, wait, we should be having ambulance services. Oh, this was one of the states, and they didn't have. So now they're pushing for us to support them to come up with their ambulance services. So the politicians have been reacting and realizing that, yes, we need these things now, not later. And so, as I said, we thrive in emergencies, which is not necessarily supposed to be where we're supposed to be, but I think having all these emergencies has pushed government further and further to realize that unless we fix this, we will have more and more people dying. And especially now with state governments, those people are their relatives, their parents, their mothers. And so there's a bigger drive from internally for them to fix the system. Of course, they don't have the resources immediately, but at least they're starting to prioritize the resources.
Yeah, I mean, having government prioritize that and see the emergency and respond to that is fantastic. I'm curious, Ben, to go back to thinking of you as a pre-emergency physician, working in your residency, dealing with an emergency patient versus you now. Tell us a story from then to now and how that's changed.
Well, there are many stories, especially if you work in the emergency department. It's all exciting. I think I remember vividly. I think the few cases. The one case I remember was just being an intern and being called. I think I just started learning how to do some emergency procedures, and being called to this child who was not breathing in the neighboring ward. I was an intern then, and going there and Of course, the child was not breathing, so I had to put a tube down the child's throat and and start pretty much using a bag to provide oxygen to the
Can you
baby.
explain what a bag means?
Like when they're bagging, they press a bag to push air into the baby's resuscitation. Yes, that one. Yeah, so to push oxygen into the baby. And so it was the middle of the night, and so I mean, it's fine. The baby is alive now. So it's you press once every 3 seconds. That's the protocol. And so that's fine. But I'm like, okay, well, we don't have a ventilator around. The ICU is not really there. It's not there. So now what? And I have to go see more patients who are coming in. So it was sad because I think it was like 2, 3 a.m. in the morning, and I had to teach a mother what to do. I'm like, okay, so this is what you're gonna do. This is for your child. You just have to press this bag up to this point because you don't want to again blow up the child's lungs. Once every 3 seconds. So 1,000, 2, 1,000, 3, 1,000 press. So I taught her, watched her do it, and she was fine. I told her, okay, I have to go see other patients, unfortunately. Yeah, hopefully we'll try and figure this out, or someone will figure, because it wasn't even my ward. So, yeah, so I left that. I never really went back to see what happened. I'm not sure what happened to the child. But I think that for me was one of the reasons of like, we can't continue like this. We actually need to have proper systems. We can't have patients resuscitating their own children. That's not how this is supposed to work. I think that for me has always stood by me in terms of trying to figure out how do we keep fixing this system, because it can be fixed. It just needs us to put things together. Yeah.
This year has obviously been a big year for the development world with the death of USAID, reduction in funding from other multilateral sources. I'm curious what both of your thoughts are in terms of your personal thoughts, in terms of where we're going, but also how your organizations have had to deal with the fallout and how philanthropy has come to your aid or not.
Well, I think everybody knows the world is living in new era, and I think the international aid has been just, I think, most impacted sector, industry than anybody at this point. Let me take back to Nepal again. About 20% of our health budget was, it's always like international aid. So that is quite significant. That is the money that just goes for the programs. About 11% of that budget is from the USAID alone. So they are a big player. And plus, we also lost one of our, 1/4 of our funding, which was just awarded last year. That has really changed the global health. At least Nepal's health system has been really kind of, in a very shaky place right now. But it's not the end of the world. I think if it was really being informed well and really discussed well, I think we could have done it in very, proper way. But that is how the reality we are accepting now. So what we did is, yes, it is impacting in just every sector, including emergency services to the big development aid to the big trainings, system policy to the just the last mile. So it has a very, very big impact. And I just I don't think there is any means that we can really kind of feel any funder can fill that gap. But we have taken some measures. I think that really kind of we are seeing some progress, and I think we were much worried as we are maybe not now. So first thing we talked to government and all the partners, because we also lost our funding, so we have to inform everybody. It's a crisis communication, including you and everyone. So this is what it is happening, but we are going to navigate this. So we informed everybody, this is what it happened, which particular program all. And then we sat with, the team. So we need to reprioritize our work and also talk to government, because we are in an ecosystem of health system that we were trying to fill that gap where we can where we can really bring the momentum. So our funding was very critical for for this sector, because we invest where there is a there is biggest return. That's really how we invest our program. So, but when this big funding is gone, then it really kind of imbalances everything. So we have to reprioritize everything. We sat with the government. We looked at what are your big priority, what are the emergencies you need to deal today, what are the emergencies you can deal in next year, and what are the long-term goal which we can think later. So we really kind of had a short-term strategy, mid-term strategy, and long-term strategy. And based on that, we also reprioritize our activities, even though we lost our funding. So we talked to everybody, in our funding pool, and most of funders really responded very positively, and some of them really provided some emergency grant to deal with the situation, which was really kind. And then government was also, bringing some resources. Okay, this is really important. Maternal health is like a #1 priority for the country. All the services is free. They get the incentive coming to the facility. They get financial incentive. They get clothes, and all this is very much, like a #1 priority. That's why we were able to really go from 539 to 151, because the government has a huge commitment. So they really saw that this is an urgency of, some action. So we sat together, prioritized the activities, and also internally where we can really be efficient. So, maybe the infrastructure projects, yes, let's do it, but let's prioritize. So we looked some of the cost cutting, including admin cost, salaries, not adding the staff, freezing the hiring, just a lot of different kind of strategies that really kind of help us to navigate that situation. And then we are also kind of changing a little bit of our direction. Maybe, we were always a very diverse organization, but our funding was starting to come from more government funding. Then we started going back to okay, let's do the individual funders, philanthropic funding. And so we took a lot of different approaches. I think coming back like now it's 9-10 months. I think the challenge is still very much there, but I think we are really kind of heading away from that challenge.
Mm. And Ben, I know emergency services don't rely on multilateral funding as such. It's a government funding initiative, but I'm curious what you've observed in terms of the death of USAID and what the impact on the Kenyan government was, and therefore on emergency services.
Yeah, I think that's the interesting part about international aid. So international aid has, for the longest, well, it still does, fund vertical programs. I mean, like maternal child health, as Surya said. So they'll fund maternal child health, but when the mother is bleeding in the community and she needs ambulance services, oh, sorry, we don't fund that. They'll fund malaria, and when that person is having seizures in the community and stopping breathing, oh, that's not funded. So I think the assumption has been emergency services exist in many low and middle income countries, and what we need is to support this vertical program. So there's, at least in many low and middle income countries, and even in Kenya, there's no funding that goes directly to emergency healthcare services from international aid. And so when international aid essentially was cut off, like you said, so a lot of the vertical programs actually started, the government had to step in and re-strategize a few things. But of course, we don't know the impact in terms of mortality and morbidity. We don't have that. I think that data will come out a bit later. But a lot of the programs pretty much got shut down. A lot of staff got laid off, were being funded. From an emergency care side, at least as for us as an organization, we were wholly supported by philanthropy, and still are supported by philanthropy, which is really nice, because I guess it's a gap. It's a gap that's not funded at all. And so for us as an organization, where we were not directly funded by USAID and we watched some of the programs come shut down, I think there's also was a big realization, even from a government perspective, that we can't continue depending on aid as a government. And our services need to be built and reinforced within existing government policies, government laws. So even now, as we have more and more conversations with government, they're more keen to ensure that whatever systems we are putting in place, they can fund them. And sometimes actually, because always in our report, you'll always find the statement that we can only move as fast as government, because now government is more deliberate to say, okay, if we're putting it in law, if we're putting it in the policy, that means we'll fund it. So sometimes our programs don't move as fast as we want them to move, because we have to continuously just work with government, for government to get to the point where they can commit to this being done. And the good thing is, I mean, government does commit, and so, because you'd expect, I mean, oh, we should have 47 policies on emergency care, we should have 47 on public ambulance services, but it's not that easy, as Surya mentioned earlier, in terms of government planning, then government budgets. So the progress of emergency care development in Kenya has really been governed by the speed at which different governments are working, but wholly funded and supported by philanthropy, which has been fantastic. I don't know whether international aid is coming back, but I still would advocate for international aid to look at funding emergency healthcare services, because it really supports all the vertical programs that they're busy running, and there's need to invest in emergency healthcare services. It will save all the mothers and babies Surya is trying to save. It will save all the people with malaria, tuberculosis, who need emergency care at some point, and probably will reduce numbers holistically across the board if we build our emergency healthcare services.
Fantastic. Now, you've obviously achieved a lot over the last 10, 12 years. Looking ahead, 5 years, 10 years ahead, given the current landscape, what are your plans? What are you hoping to achieve?
So as mentioned, 50%, we need, so I think we have already 10 public ambulance services. So by 2030, we want to, 2027, sorry, we want to have 24 public ambulance services up and running. We want at least 165 or so of the emergency centers up and because when I say emergency, again, it's not what you've seen on air. It's a very dark room with no beds, but we want really to upgrade them to the point where you, as seen on TV, just a bit, okay, with trained providers and have the equipment to provide emergency care. From a policy perspective, the remaining states that don't have policies to already have put that policies. And to be honest, I think we're in that progress. Of course, we definitely need the continuous support from philanthropy to help us support government putting this in place. But the good thing is, whatever we're putting in place is being sustained by government and will continue even beyond the philanthropic support that we initially get.
Fantastic. And Surya, obviously you've done a lot to reduce maternal mortality, but neonatal mortality is still a bit stagnant. There's a whole bunch of other things that you're looking at. What are your plans for the next 5 to 10 years?
Oh, well, the world is changing very fast. We are seeing a lot of new challenges. The climate is real. Climate change is real. We are seeing more flood. We are seeing more landslide. Maybe more. Nepal is always this high vulnerability region. We have all the highest mountains, but it all comes with cost, of challenges. And also, the maternal death is improving. I think decreasing quite rapidly, but it's still a long way to go. We still have to reduce more than 50% in next 5-6 years time. Newborn death has been stagnant, 22 from last 5 years, per 1,000 live births. We need to get to the 12. So we need to have some, like a very condensed, targeted intervention we need to take. So there are a few things that we are also, trying to embrace in this new challenges. Plus, what we will be continue doing what we are doing best, but we will also be doing a couple of new things to, position ourselves with these new challenges. So we are seeing this, newborn death is a big challenge. So we are doubling our effort in newborn program, increasing the more NICUs are there, newborn care are there. The mothers are really trained, are educated about this. The healthcare providers are trained on how to manage the sick newborns. So that is something we will be very much prioritizing over the years. We will be working on, one of the things that, even the maternal death is decreasing rapidly, but the postpartum hemorrhage is still very high. About 60% plus, almost 2/3 of maternal death is just happening because of postpartum hemorrhage. So we need to have a very focused intervention on that. We're doing a couple of new ideas, bringing this new medicine, working with government to bring this medicine that doesn't need the refrigeration, so the heat stable carbohydrate. We're working on that. So if we can introduce that to all the facilities, so in remote areas they can access this medicine, and then it is very effective drug listed by essential World Health Organizations essential drug list. We are going to work around the new challenge that the maternal mental health, perinatal mental health. We are seeing that around 6% of maternal death was just because of suicide, and about 10 to 17% of women they go through this perinatal depression during childbirth, and that is very significant. And we have a very limited program in the public health system and primary healthcare system, so we really need to do something. So we are also going to work on that area. I'm going to meet with someone actually very exciting tomorrow with Mark, who has really done this in Australia about perinatal mental health, and also we are going to work around the climate, because that's going to be a kind of a big effort. Climate is much more like not only responding to the emergency, but before the emergency, like where they can have a better health facility, like that is not flooded, that's not going to be flooded, landslide and all. We are trying to really prevent that when we set up these birthing centers or health facilities. And then also they have a cold, sometimes winter is very cold, so they should feel really warm being there, and in the summer it gets hot, so they should feel comfortable being there. So we are going to work on our infrastructures modeling that we have been working in the past. So yeah, these are the really kind of areas we are going to work, and using the more technology, and digital health, trying to work on more new best practices in the program, and improving the way of how we deliver the program, and also making more policy level work, because One Heart has really gathered a lot of data, evidence, best practices, like we are doing with ultrasound. We hope that in next 5 years, we will able to really can bring a lot of new policy system approach that can be benefited Nepal and beyond Nepal. And by then, in next 5 years, we came with new strategy. We are hoping that to tripling our impact, we reach about 1.5 million in population, pregnant mother and newborns as of now. Our goal in next 5 years is to triple the impact, 4.5 million. That's really kind of our ambition, and reach all the districts in Nepal by 2030, where the maternal newborn health needs is highest, and then bring that expertise and service beyond Nepal. That's really what we are thinking about.
Ben and Surya, I've had the privilege of speaking with you both separately on Philanthropod and today on Philanthropod Live together. You both are working to challenge really complicated and challenging contexts. And so I thank you so much for your work. You're both dead set legends. And I thank you for your friendship, your leadership and your courage in the work that you do. And to everyone who's been here today with us, thank you so much for joining us on Philanthropod Live. Until next time.